My name's Aaron. I'm orthopedic surgery resident here at McMaster, and I'm completing my master's within the HRM program. And I'm going to be talking today about defining minimally important differences in functional outcomes for musculoskeletal oncology patients that are undergoing lower extremity endoprosthetic reconstruction. Just some disclosures. The data from this study was based from the Parity trial, which had a number of funders as well. I received some salary support over the last year. Just a little bit of background. So about 95% of patients with bone sarcomas are now treated with limb salvage surgery and endoprosthetic reconstruction, which you can see on the right there. This has been a shift from amputation, which used to be the standard of care. And because of the shift towards limb salvage surgery, there's been an interest in defining functional outcome scores for this patient population. The most common functional outcome scores utilized are the Musculoskeletal Tumor Society Rating Scale, as well as the Toronto Extremity Salvage Score. So minimal important differences go hand in hand with functional outcome scores and patient-reported outcomes. And it can be defined as the smallest difference in score in the domain of interest, which patients perceive as beneficial. And that was first defined actually here at McMaster back in 1989. I like to give the example of patients with knee arthritis, and we're looking to see if knee injection is beneficial for them. So we could measure their pain on a 10-point scale. And for example, everyone could have a pain of 4 before the injection and 3.5 afterwards. Now, if you have enough patients, that could be statistically significant. However, whether it's clinically significant or meaningful, or if patients can perceive a difference in 0.5 is unclear. So that's why minimal important differences have been created to define these cutoff scores or change scores that are actually meaningful to patients. So in orthopedic surgery, MIDs are widely reported throughout the literature for essentially every functional outcome and patient-reported outcome that we have, with the exception of the MSTS and the test scores. This is because in musculoskeletal oncology, it's a very rare disease, and the majority of the literature on functional outcome scores come from case series that administer the outcome score at a single time point. So MIDs have been difficult to establish. So the objective of the current study was to define MIDs for the MSTS and tests in this patient population. And so this was a secondary analysis of the recently completed Parity trial, which was a multi-centered clinical trial investigating the impact of the duration of postoperative antibiotics on surgical site infection. And so functional outcome scores were administered throughout the trial to the participants. And so both the MSTS and test score were administered preoperatively, as well as at 3, 6, and 12 months postoperatively. The MSTS is a physician-led score, and the test is a patient-reported outcome, both focused on patient function. And they're both converted from a 0 to 100 scale, with 0 being minimal function and 100 being perfect function. So there's 2 main ways to establish MIDs, the AnchorBased method as well as the DistributionBased method. The AnchorBased method establishes an MID by relating the difference in the outcome score to a patient-important improvement or deterioration that's captured by an independent measure, which is defined as the anchor. And the anchor questionnaire that we use, you can see it here, is a basic function score from 1 to 4. And so the anchor was administered at the same time points throughout the trial. So patients that report changes from one adjacent score to the next in the anchor represented patients who had a minimally important difference. So if patients went from completely disabled to partially disabled, we correlated those changes to changes in the MSTS and test scores to develop our MIDs. We then took these scores and we used a receiver operating characteristic curve to differentiate between patients with functional outcome scores who reported a change of 0 compared to a change of 1 on that external anchor. And then we use Uden's index to define optimal cutoff scores. We also went ahead and defined the MIDs using distribution-based methods. And distribution-based methods rely solely on the statistical characteristics of the study sample. And so we did this in two methods that are commonly reported in the literature, using the 1/2 of the standard deviation of the baseline scores. And then we also calculated it using 1/2 the standard deviation of the change scores from pre-op to 1 year post-op. So of the 604 patients that were included in the parity trial, 591 had functional outcome scores that were available for analysis. The average patient age was 40, and the distal femur was the most common site of disease, and a primary bone malignancy was the most common diagnosis and reason for operation. You can see the average functional scores at the time points that they were collected, and you can see that they increased steadily from the pre-op baseline to the 1 year follow-up. Here's a visual representation of the receiver operator characteristic curve analysis for both the TESS and MSTS that differentiated patients with no change in function to patients with a change of 1 in function based on the external anchor. And based on this, and then utilizing Uden's index, we calculated MIDs for the MSTS to be 12 and 11 for the TESS based on the anchor-based method. We also, as you can see here, calculated based on the distribution-based methods that I talked about earlier. So these MIDs represent the first estimates for the MSTS and TESS in the literature. And the idea is that they can help facilitate interpretation of treatment effects. So for example, if we create a new rehabilitation protocol for these patients post-operatively, we can see if that rehabilitation protocol not only leads to a statistically significant difference in functional outcome scores, but also a clinically significant difference in functional outcome scores. And we also hope that this can help guide future sample size calculations for trials that involve the TESS or MSTS. There's often an ongoing discussion of whether to use the anchor-based or distribution-based estimates. Anchor-based are generally preferred because they're grounded in changes that are important and relevant to patients. However, it's important to note that poorly crafted external anchors can be misleading and may not accurately represent changes that are important to patients. And external anchors that are only administered at a single time point may be limited by recall bias. But given that we didn't suffer from any of these limitations, we recommend the use of the MIDs that were derived from our anchor-based approach. Some strengths of the study: we utilized patient data from 48 different clinical sites in 12 different countries. And it's a robust, prospectively collected data set that is unique within the musculoskeletal oncology literature. And as I mentioned, the outcome scores were administered over time. Some limitations: the results shouldn't be extrapolated to other patient populations, such as patients with non-operative bone tumors, like a patient with a lymphoma, or patients who are undergoing endoprosthetic reconstruction for non-oncologic indications, such as a fracture. As well, we were limited with 1 year follow-up, which may not represent long-term function in this patient population. Thank you.